Hi everyone, welcome to our webinar today. I'm Helene from Westvic PHN and Jade, my colleague, is working alongside me. I'd like to begin by acknowledging the traditional owners of the land on which we meet today. I'd also like to pay my respect to elders past and present. So welcome to today's webinar and thank you all for attending. A little bit of housekeeping for our PHN. The majority of our webinars events are recorded and freely available on our PHN Learn YouTube channel. We do have the practice communique that goes out fortnightly with the internal and external events. Just to keep in mind a specific event that we've just put on, the supporting young people and their families through grief and suicide death. That's just come on this week. That's come from a case that we've had in our local region, and the mental health professionals have asked us to put that on. They're all on our website and there's some information on the front of the screen there. For today's meeting, participants attending will be put on mute for the course, and should you have any questions, just type them in the questions box and I'll ask them on your behalf. They'll all be asked anonymously. Please make note of the Westvic PHN Health Pathways relating to this topic that's on your screen at the moment. And I'd like to let you know our presenter for today is Ruth Crampton, Manager Member Education Avant, and this event is being coordinated in partnership with Avant. So thanks, Ruth. I'll now hand over to you.
Thanks everyone, thanks for having me. I'll just check my slides are up and running.
Yes, they are.
So beautiful, thank you. So today I've been asked to talk to you about managing difficult patient situations, management of patient complaints. We'll talk a little bit also about difficult staff conflict or staff interactions, because it's really part of the same skill set, dealing with difficult or challenging situations. So let's get started into it. Now, for those of you that don't know who Avant is or what Avant do, we're an insurance company that indemnifies doctors if they get sued. And so we also have a law firm that protects doctors or represents doctors in court if they get sued. We also manage practice policies and insurance for practice-related matters. So my role in terms of education is teaching ways to avoid risk and reduce risk, both for practices and for doctors, so that they're less likely to get sued, which is better for patients, better for staff, and better for Avant. One thing we do have at Avant is a lot of information and data based on a big database of patient complaints and legal matters. And so we pull that data out and can develop some quite interesting statistics. So I guess one of the first things I want to say about difficult patient situations is that sometimes it's from the perception of the patient, sometimes it's from the perception of the doctor. And so there was an article in the British Medical Journal that mentioned doctors described 15% of their interactions as difficult with patients. Whereas on the other side of things, Avant has data that says 1 in 8 claims involved an element of the patient feeling that the doctor was disrespectful to them, and that was things about poor communication, not spending the time with them that they needed, you know, saying things that they thought were inappropriate or rude, aggressive. And often this incident was not the main reason the patient had made the complaint, but it was a contributing factor to the complaint. So it's just useful, I think, to look at it from the perspective, I can never say that word, both sides of the coin. One thing that I like to think about when I'm talking about situations that are challenging or difficult in our workplace or in life in general is this concept of the circle of influence, circle of control. And I say it all the time, it's not in my control. Or is it in my influence? No. Is it something I can control? Yes. And so this concept was developed by a chap called Stephen Covey, and he wrote a book called 7 Habits of Highly Effective People. And one of the things he said was, be aware of what you can control and what you can't control. Work on the things you can control and don't stress so much about the things you can't control. So for example, what we can control, what's in our circle of our control, is really all about our response to events, how we respond. That's what we can control. We can't control the other person in the situation or the other side of the coin, but we can control our response to it. And then the next thing, the circle of influence, is about what things can we perhaps modify or change or adapt to improve the environment. So in terms of a practice situation, this could be systems and processes that may give the patient a better experience. So for example, if they're waiting in the waiting room and they come to the front desk because they're angry about their wait, then one of the things you might be able to influence is changing the scheduling or the structure about appointments, so that they're not, you're improving their experience, so they're less likely to come to the desk angry. So you can't really control their response, but you can just influence the things around them that may make them angry. I have an analogy along these lines, which is if it's raining and you want to go to the shops. So you can't control the rain. You can be concerned about the rain, but you can't control it. You've got no control over the rain. You can influence the impact the rain has on you. So you might decide to put a raincoat on, have an umbrella, drive instead of walk, go at a later date, or a later time in the day. So you can influence the impact the rain has on you. What you can control is your attitude to the rain. So whether you're going to skulk through the puddles in a bad mood because it's raining, or whether you're going to, swing your umbrella around and sing in the rain, that's the bit that you can control, your attitude to the situation. Okay, so just some general advice now about a difficult patient situation. So going back to that, what you can control, what you can't control, it's really important to think about the situation and try and look at it from a lot of different angles. So the first thing is this about the patient? What is it about the patient that's put them in whatever the situation is, whether they're, making unreasonable requests, whether they're aggressive or angry, whether they're complaining, whether they're particularly needy, whatever the situation is that makes them difficult to deal with. And this can have a lot to do with the patient's past experiences. It can have a lot to do with their medical history, if they're in a lot of pain, if they're really anxious about biopsy results or test results, if they've got a child and they're anxious about the child, if they've been mistreated or had a bad experience in the health system in the past, they can bring that baggage with them. So it's all about trying to put yourself in the patient's shoes and just try and imagine what their issues might be. And then the next thing to think about is it's you. It's too black and white to say in the world everybody is either 100% right or 100% wrong. And usually what happens in any situation is there's a bit of wrong on both and a bit of right on both sides of the coin. So always look at yourself and see what things are it about you that make you contributing to this situation. So are you hungry? Are you grumpy? Did you have an argument with your partner at home? Are you homeschooling your kids and they're driving you crazy? Like all the things that might be happening in your life that might make you grumpy. I've worked with particularly grumpy doctors in the past, and unbeknownst to me, they were going through a divorce, or they had had a bad health diagnosis, or there's things going on. They may have a patient complaint or being sued, and they don't want to share it with the practice because they're embarrassed. All these kinds of things. So just try and think about the things that might be contributing from your perspective. And finally, is it the system? And from a practice point of view, the systems and processes are a really important part of the equation. So what do you have in place? How can you improve it? What can you do to, streamline processes, improve processes? One of my friends was telling me a story recently when we did this talk with another group, that the practice she worked in had a really ancient, archaic phone system. And the patients always were complaining about the phone and how they could never get through. And so they did some analysis of the patient feedback survey, and they found that the first couple of minutes of every GP appointment was spent with the patient complaining about the booking system and the phone system. And if you add that 1 or 2 minutes together for the whole day and think about how many what percentage of those 5-minute or 10-minute consultations were taken up with the patient complaining. It became a really big problem for that practice. And even though it was expensive to change the phone system, they actually they had to, because it was just being too detrimental to their patient's experience. So if you've identified a situation, the next thing to do, if you've reflected on it and you're reflecting quickly in the moment, if there's anything you can do to identify what the issues are. The really important thing here is to listen to what the patient's saying and to try and get to the bottom of the issue. So, and sometimes you need to, put a name to it, or, name the elephant in the room. And you need to say, what I'm hearing is the experience with the car park is what's made you unhappy today. Or what I need to let you know that the way you're speaking to me is not acceptable. And so can you take a minute to calm down, and can we have a more reasonable, conversation? Or, just naming it, whatever it is. If they're being aggressive, if they're swearing, if they're, in some way impolite, name that behavior and ask them to address it. Or as you're listening to what the problem is, try to get to the bottom of the problem. So what I hear you're telling me is, you got sent a referral, but it wasn't to the specialist you wanted, and that's why you've come back today. Or you're unhappy today because you needed to make an appointment to get this work cover form completed, and you don't think you should be paying for an appointment for that. Just try and name and summarize to them what the problem is, and put it back to them. Be really curious, ask them questions, try and get to the bottom of it. Don't try and win an argument. It's not in our personal lives or in our nature. Often we want to win the argument. We want to be right. Actually, no, it is appropriate for you to be doing this, and I can prove it because, the facts show that, patients that do this the right way have a better outcome or whatever. You're not going to win the argument. Just let them talk, try and identify what the problem is, and let them know that you're going to try and help. That's really the best you can do. You can try and kindly correct any misperceptions or misunderstandings they have, but don't be in a position where you are raising your voice and trying to escalate the situation because you're angrily trying to put your point of view across. That might be an appropriate, behavior in a personal situation, but in a professional situation, you're really just trying to speak quietly, stand back, be calm, listen, let them get it all out. They just want to get it all out and be heard, and so just let them do that. However, in saying that, there is, of course, acceptable behaviour, what is and what is not acceptable in your practice. So you do need to set boundaries. That's not an acceptable way to talk to me. I'm going to hang up this phone now, and I'd like you to call me back when you've calmed down a bit. Those kinds of set the boundaries. Can we talk about this in a different room, not in the waiting room? Those kinds of things. So all practices should have an acceptable behaviour policy, a policy that outlines what is and what isn't acceptable from your patient's perspective, but also from a staff perspective, and even including things like you're expected to pay for the appointment at the time of the appointment. We would like you to contact us if you have any, any complaints or problems, but, just outlining what it is and what it isn't. I guess, one of the really important things is that it's a responsibility of any practice to provide their staff a safe work environment. It's it's an health and safety responsibility, and so it's important to make sure that everybody is safe. Has anyone out there want to put a comment in the chat if they've had a situation where they've felt unsafe in their practice? I used to nurse in an emergency department, and I had lots of situations where I felt really unsafe. And so it's important to have a plan for your staff about what happens if they feel unsafe. And it's not just, it should be documented in a policy, but also people should practice. The staff should all be aware. there was one situation in a practice where they were telling me that they had an emergency button, and a doctor in a consulting room felt unsafe and pushed the emergency button. Everybody heard it, but nobody knew what it was, and so nobody responded because no one had ever practiced or even heard the noise to know what the noise meant. So it'd be interesting to know how many of you have a safety outline and how many of you have practiced it. I mean, it's the sort of thing like the doctor should never be in the consulting room where the patient is sitting between them and the door. The patient should always be swung around so they're sitting away from the door. So the doctor always had the opportunity to leave. Same for your reception staff. Where are they located? Are they safe behind their desk? Can patients come behind the reception area if they wanted to? You know, that type of thing. Has anyone had any dodgy, unsafe situations?
Yes, I do have one here, Ruth. Yes, yeah. Patient drinking alcohol in waiting room and was yelling rude comments. Yeah. And so is there a policy? Think about, I know you're coming from different areas, but think about your practice, and is there a policy in place when a person is behaving unreasonably or making you feel unsafe? Is there such a policy, and do you know what it is and what you should be doing in that situation? You don't need to answer the question, but it's good to just ask yourself these things so that it's the sort of thing that you don't want to find out when it's too late, right? You want to find out before the information is needed. It's like all of those safety, you know, policy things. You want to practice it when you don't need to know it. I mean, I certainly had. And this was in a hospital environment, but it was a patient who had had brain surgery and had a cerebral sort of irritation, and so they weren't themselves. And I went into the room, and I was at the foot of the bed picking up the medication chart, and the patient kicked me in the face. And I was young, and it was really horrifying to me. And I had a big bruise and a sore face. And I took a day off work, and then the next day when I went back to work, I was allocated the same patient, which I thought was a little unfair. But anyway, he'd come good, and he was a lovely man, and he said to me, you know, I don't remember much about the last few days, but your face is familiar for some reason. And I think I didn't have the heart to tell him what had actually happened. But you need to know, if you find yourself cornered, whether it's the patient's fault or not, you know, how to keep yourself safe and how to keep your staff around you safe. Really important. So one of the things we find at Avant in terms of patient complaints and patient problems is this whole concept of what a patient's expectations are. And their expectations can be reasonable. You know, I have the expectation that the doctor will give me the time that I need, that they will examine me thoroughly, that they will do the test that I need, you know, etc. Those expectations are reasonable. The problem is when the patient comes with expectations that are unreasonable. And the thing is that you won't know that they've come with unreasonable expectations unless they say something or something goes wrong, or you become aware of what those expectations are. So you can do a few things about this. One of the things you can do is, you know, have some information available on the website or in the waiting room that outlines to patients what the expectations should be. So, for example, you know, when people send an email, you know, this email is not monitored, or this email we will respond within 24 hours. Like, their expectations shouldn't be that the practice will respond immediately. This email is not for clinical care. You know, they can't email the doctor a question and expect an answer. That type of thing. Expectation setting in terms of new patients wanting drugs of dependence, or you know, coming to the appointment with a long list but only booking a short appointment. So, you know, if this is your first appointment at this practice, you need to book a long appointment. You know, those kinds of expectation setting. If you do come across a situation where the patient's expectations and the practice expectations aren't aligned, then you need to deal with that and make sure that you reinforce what you can do and what you can't do. And if there's been a misunderstanding, apologise if you need to, and just say, I'm sorry that your expectation was, you know, that we could give you an appointment today, but your matter isn't urgent and we don't have a vacancy until, you know, Wednesday afternoon, or whatever that situation might be. And a little apology goes a long way with someone. It's very hard for someone to remain grumpy once you've apologised for the situation.
So for example, a situation, and it's common in every practice every day, is where a patient arrives and you know they're going to have to wait, or the patient's been sitting in the waiting room and you know they've been waiting there a long time. You know, I went to a specialist appointment recently and they rang and asked me to come in early. And so because I'm working from home, I could come in early. So I got there the hour early that they asked me to arrive. And at some inconvenience, I had to change meetings and the like. And then by the time they saw me, it was 2 hours later. So even though they asked me to come in early, they didn't see me for 2 hours, right? That made me grumpy. So, and no one spoke to me in that 2 hour period. So I'm interested to hear in the chat from you what types of things, policies or situations you have in place. Do you do anything to preempt the situation or trying to preempt the grumpiness when you know a patient's waiting? We should have a ticking clock. Tung, 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 tung. Any comments from anyone? My challenge is that that I think you should think about it, and again, an apology goes a long way. So if you know someone's waiting, or if you know a doctor's running late, or if you know a doctor always runs late, you know, have a strategy in place about how to address that with the patients in the waiting room. Because what we find is that if it's like it's the last straw that breaks the camel's back sometime. So it's not just one thing that makes the patient unhappy. It's multiple things. So waiting in the waiting room will start them on the bad foot, and then they'll go into the consultation grumpy, and then if something doesn't go their way in the consultation, they'll leave even grumpier. So you need to try and make sure that the patient interaction with the practice from the minute they walk in the door is a positive one. Again, just something to think about.
Couple of comments.
Yep.
We advise clients of their wait time and keep them updated. Apologies to them in advance. Acknowledging patient, smile, eye contact.
Yep. Yep. So it's really important not just to ignore them and try and pretend they're not there.
And there was another comment. There's sometimes issues sometimes with language and literacy.
Yep. So tips on how to manage that. I guess it's another one of those situations that you want to have a strategy in place before it happens. So a clear policy about who to contact and how you're going to manage a situation where the person has linguish. You think I had English as an alternative language. English is an alternative language. So for example, what's the practice's policy on family members acting as interpreters? What's the practice policy on chaperone or additional people within the consultation with or without the patient, you know, with the patient consent, you know, those kinds of things, so that you can establish ahead of time how you're going to manage it. Like everything, it's all about the preparation and the planning.
And another comment, rural working issues with call out and ED, great receptionist communication.
Yes, so you're saying that if you're in a practice and the doctor has to run off to an emergency, making sure that the patients waiting are aware of that. Is that the question?
I do believe so.
Yeah, I'm guessing that's right. And I think most patients are very understanding, especially in a rural community, of the necessity for the doctor to run to an emergency. So again, it's all about the communication, isn't it? And the keeping them posted and having a plan in place. When the situation occurs, this is what we do. We notify the patient, we give them a 30-minute, you know, an option to leave or come back with a 30-minute warning, or, you know, whatever the plan is.
And just one more comment. Give options to patients. If there's been an emergency, and ask if see another doctor or come back later.
Correct. And that's the perfect answer, because you already have a structure in place to know how to deal with the situation before it occurs. Any other kinds of difficult situations or difficult patient interactions you want to talk through, or you want me to and give some tips on? I mean, these principles you can kind of adapt to most situations. Look at it from the other person's perspective, try and get to the root of the issue, apologize if needed, don't try to win the argument. One thing, I'm going to say it on my next slide, I was going to say one thing I haven't seen is document. Different types of difficult. We get a lot of calls about separated parents and one parent coming in with the kid, for example, wanting a vaccination, or wanting access to the kids' records and the other parent, you know that the parents are acrimonious, or you don't know if they are or they aren't, but you know you've never met the dad before and you've only ever seen the mum, you know, and how do you manage that situation, which is simply that each parent has equal rights, and this is a court order to the contrary. So either parent can consent individually.
I do just have a question.
Yeah.
If a patient is complaining at reception about something the doctor has done that they are unhappy with, what should the receptionist say in response?
So I think if the patient's about to see the doctor, I think the receptionist should encourage them to talk to the doctor directly about it, especially if it's a clinical issue, but warn the doctor before the patient goes in there that they're coming in with a complaint or something to be grumpy about. If the patient isn't seeing the doctor and is complaining about something about the doctor's care, it's always good to encourage that, because you would much rather, and we talk about this a bit more in the complaint section, you would much rather the complaint comes to you as the practice rather than going to an external Google review or, you know, APRA or, you know, one of those other entities. So you want to encourage the patient to air their grievances and ask them to, you know, put it in writing or to, you know, put the details down so that you can get back to them about it. And then the doctor has the opportunity to reflect on their notes and reflect on the situation before they respond to the patient.
And another question, when doctors run consistently late and patients say, why do you make appointments if I never get in on time?
Yeah, that's a practice management issue, and the doctor needs to be managed in terms of their scheduling. You know, and that needs to be, something needs to change if they're consistently running late. Something needs to change about the way they're scheduled.
Okay, nothing else at this stage.
Thanks, everyone. All right, so moving on. If you've had a difficult, and I was going to say things like drug-seeking patients and those types of things are other kinds of difficult. So if you're talking about a difficult situation with a patient in particular, and it's particularly if it's like a one-on-one, the patient's blown up in front of you, you know, before or after the consultation in the reception area, or, you know, that kind of interaction. The patient's grumpy for whatever reason. It's really good after the event to think about what happened, and it's always good to reflect on what you might have done differently to try and nip it in the bud, or what could have been done differently from a practice perspective, from a policy or a process perspective that could have prevented the situation, and reflect on how you did in terms of how you responded. Were you happy with the way you responded, or did you find yourself getting angry and irritated, which is really understandable when the patient's being really unreasonable. Often I find having a debrief with one or two friends at work, so that you can talk about what happened, and sometimes a friend who would have observed the situation said, oh, I thought you did that really well, or they might say, oh, I thought you got really too angry with that patient, it wasn't their fault, or, you know, they can sort of give you some honest feedback at the way you managed it. You should always write all these situations down, whether you have a particular practice place where you write them in a particular type of incident book, or whether the policy is to write a comment in the patient's notes so that the staff can be wary the next time the patient arrives. And get support and backup. If you feel out of your depth, get extra training, get advice from people more senior to you. You know, this type of conversational education on a regular basis, just to remind you of all the key points. The top tips really in a conflict with the patient is to just try really hard to stay calm, to be kind, to be professional, try and look at it from their perspective, and to work with them to find a solution. And then after the event, debrief and consider getting extra support or training if you feel like you could have done it better. So that's the difficult patient part of the talk. Any final comments about that section?
I don't have any at this stage.
I will move on to dealing with a difficult colleague. because we all have a difficult colleague or two. Conflict with a colleague is an interesting thing, and I think there's a few points to make here. I think there's a difference between a one-off single blow-up with a colleague versus an ongoing, unproductive and niggly kind of relationship that just doesn't seem to get any better. So I think in terms of working with a colleague, the same things all apply: being kind, looking at it from their perspective, trying to be professional. You know, those types of things don't change. So there's this AVID acronym, which is quite useful, which is always assume the positive about others and their behaviour. Don't assume. I mean, everybody has their own truth and their own version of events that seems justifiable to them. And, you know, there's nothing better than watching some reality TV where there's two people in conflict and each of them think they're right. And you can see from each of their perspectives why they think they're right. But what you can see as an observer is that they're both a bit wrong and they're both a bit right. You know, so just to keep that in mind. Similar to a patient, always seek to understand the other person's point of view and just pick your battles. Know which ones to fight and which ones to drop. You're not doing anyone any favors if you fight every battle. I was 40 before I got married, and when I got married, I inherited 3 teenagers. And my husband used to say to me, don't forget who the adult is, because it was like living with 3 really bad flatmates. But a friend of mine who was in a similar situation gave me some really good advice, and she said, unless it's really important to you, just let it go, because you're not going to win any friends by fighting about who has emptied the dishwasher the most times, you or them. So I always thought that was really good advice, and I do think of that often when I'm in a work situation and I think, you know, really, I'm just going to let this one go because I think the person is dealing with enough stress for other reasons in their personal life or whatever. So don't feel like you have to win every battle. And then if you are in a challenging work situation, it's good to balance that with a bit of R&R and try hard not to take all these, you know, challenging conflicts with colleagues home and let them, you know, permeate through all aspects of your life. So if it's an acute problem, I think you treat it very much like an aggressive or angry patient. In that kind of be calm, be kind, you know, put a bit of effort into it. I was given good advice from a mentor once in my workplace where I was having a challenging relationship with a colleague, and they said to me, the best way to deal with it is to have a regular coffee catch up with this person and work extra hard at trying to be their friend. So every time, once a week, we had a shift that overlapped, and I always made an arrangement to have a morning tea break together and just talked about their family and their life and, you know, all those kinds of things. And gradually the walls broke down and we actually became friends, you know, in the loose sense of the word, but we became much better work colleagues because I put the effort in to try and build the relationship. And most people do have you know, attributes that are worth knowing once you know, get past whatever the barriers are. There is a thing called the Vanderbilt Method. Now, Vanderbilt is a rich American family who have a university, and they, you know, they owned a university, hospitals, all sorts of things. But the Vanderbilt University came up with a process, and it was primarily about bullying and bullying in the workplace. And the process was that there was like an anonymous suggestion box that if you witnessed bullying, if you'd been subjected to bullying, or if you'd heard about, you know, a person being a particularly bullying sort of person, you could write a comment in this suggestion box anonymously. And one comment was never acted on. But if there was a few comments about the same person, then they started this process. And the process was that a mentor, which was somebody of the person's peers, so, you know, reception staff, another reception staff, practice manager, another practice manager, nurse, another nurse. This process is used in hospitals, and so surgeon, another surgeon, you know, that type of thing. And so the process was that you would be taken for a cup of coffee with the mentor, and the mentor would bring it to your attention. it's been observed that you are rude in this situation, or there's been some comments or some, you know, people have been hurt by your behavior in this circumstance. And what you're doing by having that cup of coffee, casual conversation, it's like pull your socks up. It's like, this is something you may not be aware of, but other people have noticed it. And then what you're asking is for that individual to reflect on their behavior, and there's a very high chance that that behavior will change. So this has happened to me before in a more informal sense. But once one of my friends said to me, I was an educator educating other nurses, and I thought I was quite to the point, you know, just said it how it was, black and white, no frills, firm but fair. That's how I would have described my behavior. But one of my friends said, I think you come across harsher than you intend, right? And I was like, really? Harsh? I'm just saying it like it is. Like, how is that harsh? But I took it on board, I reflected on it, and I really changed my behavior, and I became much kinder when I was giving people feedback. And then I worked quite hard on it. And then a couple of years later, I had a group of students, and I asked them all individually, is there anything about my feedback to you that you would interpret as being harsh? And they all said no. Now, it's not, you know, gold standard research, but I think it was an example of where an attitude or a behavior of mine wasn't ideal, and I improved it. I mean, someone also said I was louder than I thought I was, but I didn't ever change that. But you never know. So in this Vanderbilt method, the idea is that the anonymous comments are made, the person is taken aside and asked to think about it, there's a high chance their behavior will change, and there's a process if their behavior doesn't change. And the process has resulted in you know, escalation in terms of their management being involved, performance management, HR involved, and eventually several key people in the hospitals where this runs have been terminated, like the head of nursing or the head of surgery or whatever, terminated because they can't get through this process with reflecting and changing their behavior. So this is a big process, this is a big deal, but you can take the principles of this process if you're working with someone that you find has a particular characteristic or behavior or attitude that's unmanageable for you or unworkable for you. So what I would suggest is peer-to-peer, if you have that sort of situation. And often we talk about this role being that of a critical friend. So a friend that is, you're close enough to the person that you can tell them like it is, like my friend who said I was harsh. So take them aside for a cup of coffee and say, this is, I wanted to bring to your attention, this is the situation, and ask them just to think about it and just leave it in the ball in their court to see if they have the insight to change their behavior. And then, you know, if it's more of a chronic problem and that doesn't happen, then you may well need to escalate to a management level. If you are a manager, this is still a good thing to do. You can take a person who reports to you out and have the casual conversation with them. I've had some feedback that this is, you know, how it's been observed, and I'd like you to think about the way you do this, and if there's anything, and I won't have a coffee with you in 6 months and talk about it again, or 3 months or whatever. It can get difficult when you're the person, and the person you have a problem with is your manager, right? Or you're a student and it's your supervisor, or, you know, it's that kind of, you're the practice manager and it's a doctor, you're a nurse and it's, you know, the practice manager. Those kind of relationships are much more challenging to manage. And but the same process applies. I would encourage you to do the same process. So I've had a situation with a boss that was challenging for me, and so my advice in this regard is I sent them an email. I didn't blindside them. You don't want to catch them unawares and give them no warning or no chance to think about the situation. So I emailed my boss and said, I would appreciate a cup of coffee with you sometime on Wednesday. I want to talk about, and then like a one sentence about what it is you want to talk about. So I mean, I'll give you one example. It's not exactly true to the point, but it was, I would like to talk about my salary. I said that to my boss once. I want a coffee with you tomorrow so I want to talk about my salary. And then there was a few advantages to that, because then my boss could have the opportunity to reflect on my salary and my worth, and or to reflect on the behaviour that I brought up. And then when we had the coffee, I couldn't weasel out of it because I'd already said it, right? So I had to have the conversation. So from my point of view, that was good. And then we had a really constructive conversation, and he thanked me for approaching him, and then I never got a pay rise. But that's the type of situation where you would say, I would like to have a coffee with you tomorrow, and I would like to talk about, the types of conversations I've heard you having at the front desk, or or those kinds of, whatever the comment is, and then have the conversation, give them a chance to talk about it, have it in as much as a non-confrontational way as you can, and then give them a chance to reflect and change their behaviour. If nothing changes, then you've got the option to escalate it. Any questions about?
It's got a couple of comments. Thanks for being honest. Sometimes power and question mark LMGs, whatever that means.
Don't know, sorry. I don't know the acronym. Ask me a more detailed question, that person. It's good because it brings me to my next point, which is about being vulnerable. So I think one thing I would like to bring up in this conflict with a colleague, and not knowing what the other person's life story is, or necessarily what challenges they're going through at the time. Sometimes there's a grey area between being concerned for a colleague and their behaviour, and just being generally concerned for your colleague, like for them. I'm talking about their well-being, their mental health. I mean, we all know lockdown, COVID, stress, homeschooling. There's lots of reasons for people to be not quite 100% these days. And so I would just like to make a few comments about if you're concerned about a colleague. So I recently I say pre-COVID, so what's that, nearly 2 years ago now, did an Australian tour with this American doctor who was a psychiatrist, but he only treated other doctors. And so he treated doctors for things like burnout. He mentored families when a physician had committed suicide. A lot of things about difficult workplace situations, patient complaints, all of that kind of stuff. And so he had a few key tips if you're concerned about a colleague. And then interestingly, I had a colleague who had a big psychotic mental illness episode in my workplace around the same time. So I took that advice really to heart. And so the things he said was, if you're concerned about a colleague, do something. Don't do nothing. Don't wait for someone else to do something. It's really important to do something. And that something is, I noticed you're not yourself. Are you feeling okay? Is there anything you need? If you don't know that person particularly well, but you know they're friends with someone else you work with, maybe talk to the friend, and they might be the best person to approach them. But don't let it slide. Be really proactive if you're worried about somebody's mental health or their well-being. The other thing is be specific. So don't say, let's catch up sometime. Say, can I take you out for a coffee tomorrow at 10? I've got coffee on the brain, haven't I? Can we go out for dinner on Thursday night? Make an actual specific plan. Don't do the vague, let's catch up sometime. I interviewed one of our Avant members who had methamphetamine drug habit, and he got sanctioned by the medical board, and he wanted to be interviewed about his recovery and how he came back to work. And one thing he said that was really interesting was, all of the friends that wanted to take him to a wellness retreat and, find himself, and all that kind of stuff was unhelpful. But his brother, who said to him, every Monday, I'm taking you out for a coffee at 10 a.m. and every Monday you will be there, no excuses. And that constant week on week regular support from his brother was one of the things that really helped him through his struggles. So don't abandon them. My friend that had the psychotic breakdown said that for over a year, nobody from our work contacted her. Not one person, because nobody really knew what had happened, and everybody was a bit afraid about whether she wanted to hear from them or not. So nobody did anything. And then, so don't abandon them, keep in touch with them, even if it's just a text message or an email, and just check in with them and make sure they're still doing okay, because chances are they may or may not come back to work if it's a big event. Finally, be vulnerable. Be happy to talk about your stories, your experiences, things that have happened to you, because other people can really learn from that. And anything you can do for a person that's in a vulnerable situation like that is important. And this is what the doctor who was talking about his methamphetamine habit, really touchy and challenging subject, but he wanted to be vulnerable because he wanted to help other people potentially in his situation. All right, I want to move on to patient complaints because we're running out of time. So I just want you to think about difficult situations, difficult patients, and what happens when the patient comes to the desk with a complaint, because it's really, really important that their first interaction with the practice is a positive one when they come to make a complaint. And it's really important that whoever's at that front desk or whoever the patient approaches takes that approach seriously and doesn't try to deny it, doesn't try to blame the patient, doesn't try to dismiss it as trivial, doesn't put the complaint in the shredder box. It's really important there's a process in place so that everybody knows what to do if the patient makes a complaint. We recommend having one person responsible for complaints, one person who can track them, who's got an overview over all the complaints, and then you can see the trends. You can see if it's about a particular person, if it's about a particular process, a particular issue. Keep a record of them in a separate location. Make sure you have, as I say about everything, have a policy or process in place. If the complaint seems quite substantial, it's really important to ask for it in writing. Whether the complaint comes verbally or in writing, you need to respond to them within 24 hours, even if that response is just to say, we're looking into it for you, I'm doing some further investigations, I'll be back to you, you know, that type of thing. And it's really worth putting the effort in to get these things nipped in the bud, because what you don't want is the patient to escalate it and take it further. You don't want the negative Google reviews. You don't want the APRA reports. You want the practice, you want to seek complaints. You want to say to your patients, please let us know if you've got any issues on the website. Please forward any comments to us. You want to actively seek patients to give you this feedback, and you want to see it as a positive thing and make the appropriate changes. If a patient complains, there's several researchers about what they want if they complain. And really, they want you to hear them and to understand what the problem is. They want an explanation as to why the thing happened to them or why the thing is the way it is and it isn't going to change. Where appropriate, they want an apology, and there's a lot of power in an apology. And you don't have to say, I'm sorry I did this. You don't have to say that. You can say something like, I'm sorry this happened to you. I'm sorry this isn't the place either of us wanted to be in, or I'm sorry that this is, you know, that this has happened, kind of a comment. And then the other thing a patient wants is they want something to change. They want to know that their situation has improved things for other people. Mostly they have a really altruistic sort of view where they want to make sure that things are improved because of what they've been through. What you don't want to do is you don't want to ignore it. You don't want to accuse the patient of having done something wrong, and you don't want to just knock them back and say, I can't do anything about it. You need to take them all seriously and put them through the process. No matter how trivial to us isn't necessarily trivial for the patient. It's good to think about, like I call it a toolbox, but it's the things that you have in reserve that you can take out if you need to use them. So little sayings, little phrases that you can have prepared and in place so that you have them ready before you need them. So it's this kind of training and regular updates to the practice policy and things that you read to make sure that you know how to respond if a patient comes to the desk. Role playing is a really good thing. Watching little video scenarios of what's the right thing to do and the wrong thing to do. So things like, my understanding the problem is, or how can I help you? How can I make this better? What do you need from me? Or unfortunately, it's practice policy and that's why I can't, not that we would be prescribing, but, you know, prescribe you these drugs or, you know, whatever the issue is. So in terms of resolving the complaint, you receive the complaint, big or small, you need to address it. So the first thing you need to do is try and get all the facts together. So if it's a practice related issue, it's on the practice manager or the practice staff to get all the facts together. If it's a clinical issue, it's on the doctor to get the facts together, but they may well need support for that in terms of scrolling through the records to find a timeline of what happened when, that kind of thing. You need to talk to the people that were involved at the time. You need to keep a record of who you've talked to and who you've discussed it with. You need to check and find out what happened to make sure that you really understand it. You understand what the complaint is about, who it is about, what the patient wants as an outcome, and then what you need to do to follow it up, if anything. And if you say, look, I've investigated it and it was just a really unfortunate misunderstanding and we apologise, and, you know, that may be all it needs, or it may be, you know, further a change to the system or process. Any questions about complaints?
None at the moment, Ruth.
Okay, moving on. So the last little thing I wanted to cover was ending the doctor-patient relationship. And this is an important bookend to the conversation about difficult patients and patient complaints, because sometimes it gets to the situation, either the relationship with the patient and the doctor, or the relationship with the patient and the practice, or all three, where it's just an untenable position, and the practice or the doctor or the combination decides that they no longer want to have the patient on their books. And this happens not that often, but we would estimate at Avant that in a doctor's career it might happen 2 or 3 times. So I'd be interested to hear if you've ever had a situation in your practice, if you can put it in the comments, if you've ever had a situation where you've had to terminate a patient relationship. So you terminate it when the relationship is no longer therapeutic, no longer in the best interest of the patients. There's really cold, clear things where you would automatically, immediately terminate the relationship. And then there's some vague sort of grey things about behaviour and non-compliance that might be like building and building before you get to the point where you feel like the relationship is no longer in the patient's best interest. But the cold hard ones would be things like, violent behaviour, racist behaviour, hard limits for the practice, that you're just not prepared to have someone in the practice if they won't follow the expected behaviour policies. And then, the more grayer areas is like if a doctor gives a patient constant advice about what they need to do to manage a certain condition and the patient just refuses to do it, refuses to go and have the test, refuses to take their, diabetes medication or whatever, you may just decide that you've done all you can and you don't want to see them anymore. Any comments about having to end the relationship in any of your experience?
Yes. Patient was passive aggressive and not being compliant with medical advice. Yeah,
classic. So there's a couple of things to do in the process. First of all, you need to be really upfront with the patient and explain to them why you're doing this, what it is about the relationship that's untenable for you, either from a practice perspective or the doctor perspective, or sometimes it's easier for the doctor if the practice owns it, so it becomes less personal and more sort of institutional. You need to have the evidence and the justifications for your decision, and then we would recommend writing the patient a letter. Sometimes it happens that another doctor in the practice will see the patient if one doctor won't. You just need to be really clear about what the patient can and can't do. Make sure the patient records are flagged, because you don't want a situation where you go through this whole process and then the patient rings up and books with another doctor, or books with the same doctor because they've just ignored the letter and the staff in the booking system are unaware. You can't end a doctor-patient relationship in the midst of an acute episode or an emergency, so you need to finalise an episode of care before you can pass them on. And if you do pass them on, you're obliged to provide records to the new doctor. There is only one caution from a legal perspective: no doctor has to treat any patient or practice has to treat any patient they don't want to, but you do have to be careful of anti-discrimination laws. So to make sure that you're not ending the relationship because of a a religious or a cultural or a disability, or those things that are discriminatory. But if you're unsure of that, you should seek advice from Avant or a similar company that you have practice insurance with. So finally,
I do have a couple of questions.
I have to go for it.
Patient lied twice regarding scripts, saying he had lost them but had gotten them from another clinic.
Yeah, so that's a classic example of someone, the trust between the practice and the patient's been eroded, and so that would be a classic example of someone you would terminate the relationship with. All right.
Oh, sorry, I was on mute. Is it true in letter you can say they can come back in case of emergency?
I think you have to treat anybody if it's an emergency, but you really want them to seek an alternative place to go in an emergency. So my recommendation would be that you, if they turn up in an emergency, you would treat them, but you wouldn't encourage them to come back in an emergency. You would encourage them to seek care elsewhere.
And another question, just wondering, if a patient makes a rude remark or says something under their breath regarding the practice or reception or the doctor, should we respond to that or should we ignore it?
It depends. If you feel unsafe, if you feel they're being a bit passive aggressive, or you might just want to let it go in the interest of protecting yourself. But if it's something that they are clearly unhappy about, I wouldn't be adverse to approaching it head on and just saying, is there something you wanted to talk about? I'm happy to, did you want to call me, once you've come down, or, give them the option to contact you further and discuss it. I think what you don't want, we've had situations where a patient has come out of the consultation, come through reception, gotten into their car, and then got on their phone and made a complaint to AHPRA. You don't want that to happen. You want to be able to intervene before that gets to that stage. So if it's an appropriate point to respond, then you should do that rather than just pretending you didn't hear it. I guess it's a case-by-case thing, really.
Thank you. No more questions at this stage.
Thanks, guys. So to sum up, encourage your patients to give you feedback. You want the feedback, you want to hear about it, you want to make things improved, you want to make it easy for them to give you feedback so that they don't go and do it online or do it in a more formal setting. And then you need to look on that feedback in a positive way, which is not an easy thing to do, but you want to go in with the attitude of, thank goodness they gave me this feedback and they didn't give it to, ring up today tonight and talk to them about it. And then respond to that feedback. Don't go, oh, well, I'm choosing to ignore that feedback because I don't like it. Where actually, really take it on board and think about it and bring it up at practice meetings. Have a section in your practice meetings where you talk about any feedback, a patient has said this, does anyone agree? Does anyone think it is an issue? That type of thing. Be really prepared before the event, be well educated, have good policies and processes in place, practice things for safety, practice what to do for a complaint, practice how to respond if you hear someone say something grumpy about you under their breath. Make sure that the doctors and the practice staff are working in unison and giving a uniform message. Don't be in a situation where the practice staff are saying, oh yeah, he's hopeless, he always runs late, or those kinds of comments. Make sure you've got each other's back. And if you have a really bad incident with a patient or there's been some event, just consider the option of not billing them, of not charging them, or bulk billing them, so that you're not adding fuel to the fire by making them pay for what they consider to be an inappropriate or unsatisfactory experience. That's again part of the practice's decision about how they feel about that. It's more of an important point outside of the primary care setting where the billing is really high, but it is something worth considering that you know, if they're waiting for the, you know, I know practice where if the patients are waiting a long time, they give them a coffee card and they can go next door to the cafe and get a coffee while they're waiting, and then they text them on their mobile when the doctor's 10 minutes away, for example. But just, you know, little things that might smooth the waters. 2 minutes to go. That's it from me. So any questions from anyone? One thing I do have to say is that I have a lot of fact sheets on a lot of this stuff, and I've put links to those fact sheets on a PDF that's attached to this webinar with the slides. So I've got a fact sheet on conflict, you know, a fact sheet on patient complaints, a fact sheet on ending the doctor-patient relationship, etc. So there's lots more formal information in those fact sheets than we could cover today.
Excellent. No, there's no more questions. Just a comment. Feedback in brackets, complaints is food of the gods, makes you improve your service.
Too true.
I'll take this opportunity now to end the webinar, and thank you, Ruth. What a fantastic presentation. Really well received information.
Thanks, everyone. I hope it was helpful.
Yep. Got some comments, some helpful hints. Thank you. Thanks, Ruth. This was super informative. So once again, thank you. And thank you to everyone for attending. Pop your topics in the topics requested box on the evaluation, and we can certainly get some more meetings happening. So thanks, everyone. See you. Have a good weekend.
Bye.